I'd now like to introduce you to Dr. Chris Ross.
I will speak slowly. Right, now the subject I want to talk about is looking at the problem of an expensive condition in a country with few resources. And I've actually presented some similar data in Delhi earlier this year. So three of our Indian colleagues have seen some of these slides. But the aim of this is not primarily directed at our colleagues from India, but the aim of it is to bring it to the rest of the audience here, and then it may come up in some of the discussion later. Now the reason why this is important is because cystic fibrosis, in a sense parallel perhaps to something like HIV/AIDS, is a very expensive condition to look after. Made worse by the fact that if you spend money on it, then the patients live longer, therefore the cost is even greater. So it's not something that you can audit that has an end point, like a hip operation. If you spend £2,000 on a hip operation, then you've got somebody who's then not costing more, and in fact may cost less because they start earning money again. But with cystic fibrosis, if all your patients die within the first 3 months of life, then the economic burden is very small. If you then treat them for what in the days that I'm going to talk about, because I don't have today's cost, Gary may know one, but I was involved in this project at a time, this was started about 10 years ago, where the cost in the UK was $15,000 to $20,000 per year per patient average. Now obviously some were less because they were the younger ones, but as they got older they became more and more costly, and the overall cost in the UK was officially defined, and we actually did our own costing in Southampton, and it was around $15,000 US per year. Now, how can you even look at CF in India if you're going to have to say to somebody it's $15,000 a year? In almost any country, even in the United States, it's very difficult because they don't have what they call, us in England, socialized medicine, and so they would have to get grants or special things, because even a working person in America could not afford $15,000 a year for the treatment of their child without other help or support. So it's impossible. So it was with a view of this problem of the cost of CF that you then say, well, should we even look? What is the good of saying to somebody your child has CF? And actually with Sushil, when I first went to Delhi, I think it was in 98? 97. We actually discussed this very issue, and he brought out, I don't know if it was an actual patient or just a model, where you have a poor family, and you tell them it's CF, and then they learn from you or from somebody else that in England and in America people with CF can live well into adult life and probably have almost normal life expectancy, some unborn today. And you say to them, we can do it, but it's very, very expensive, and they might say, well, thank you very much, and they go home and let the child die because they've got 4 other children and it's just a poor farmer. And Sushil mentioned one where the parents said, well, or the father said, well, my brother has a cow, we'll sell the cow and have some money. How long would the value of a cow be in the care of cystic fibrosis? 2 weeks? 3 weeks? At our cost. So this is a problem, and it was a problem that arose first when I was involved with Child Health International in a project in Moscow. And Dorothy and her husband contacted me, I knew nothing of this, but they had made links with Moscow with a CF clinic that was struggling, and they had gone and talked to the people in the clinic and said, if we could get money, what would you want? And it was one of those knee-jerk reactions, which is a danger, because obviously you say to people, what do you want? And if they really know what they want, you don't impose your view. But the Russians came back quickly with a wish list of all these expensive things. Ticarcin and piperacillin, I don't think we still use them in CF, but those were the big antibiotics of 10 years ago. And these things cost £600 a week, and you needed 2 weeks treatment. And not only that, you needed to do blood levels because they're toxic and you had to measure them in the lab. Or you needed a special drip set that was very accurate to give these toxic drugs. So the wish list was unreal because they, first of all, even if you had £100,000, if you're going to pay £600 a week for one course of treatment, that's over £1,000 for a full 2-week course. You're not going to have many of those out of your 100,000, 100 courses. If you got 50 patients, which they had in Moscow, you're going to use up all your antibiotics in 1 year. So we began to sort of say, well, how can we do anything, and what do we do? The costing of their service was based on bed occupancy. That actually was an interesting one. They got money from the government for the CF service on the basis of how many children were in a bed. I don't mean in a bed, I mean how many bed days per year. And so when you went onto the CF ward, they had about 20 patients all lined up on the ward because for every patient that was there at midnight, they got money. So if we were going to improve things and get children out of hospital, the budget went down. So this was an interesting logistic. You had to get the budget and remove the children from hospital. Anyway, we said, I said to Dorothea, we can do something, but we need to look at what their real needs are, how can we really help them. And we developed a sort of project and a program which has been very successful. And what I want to do is to describe that a little bit because it is relevant possibly in India. It's certainly relevant in anywhere else where you're looking at a country that has limited resources. Now, one of the issues in England at that time was that CF health had improved enormously. Children were now living well into adult life. This is 10 years ago, 12 years ago. They were going to school, their parents were working again, everything was going fine. But if you said, what is it that actually makes them better? And the gastroenterologists, the gut specialists, of which I was one, because I'm out of the old days, we said, it's the nutrition. If only you can give them really good enzymes and you give them really good diet and good food, then they will improve, and their chests will improve simply because they're stronger and tougher. And the lung specialists who were coming in and taking over CF, and we were fighting. Yeah, I hated all these pulmonologists. They were taking away a disease that I was looking at. See, the pulmonologist said, oh, you just give them enzymes and some diet, but what you really need is good physiotherapy and good antibiotics, and if you give them good physiotherapy and good antibiotics, then the body takes care of itself. And there were actually advocates in the world. You had a group in Toronto with a Dr. Hamilton who was just all nutrition and really wasn't terribly interested in physiotherapy and the lungs. And you had some people on the continent in Denmark who said the one thing that matters is antibiotics, and if you do that. So here we were in Russia, a clinic with 50 full-time patients and about another 150 a year that they saw just once and sent back. Sometimes many, many thousands of miles. But they had 50 patients, and every year they diagnosed about 12, and every year about 12 died. And the average age of death was 11. And they had about 3 patients over 15. These were sort of mild ones. Otherwise, it was dreadful. So we thought, this is a chance. Let's find out. I was being selfish now. I said, you know, the nutrition's important. So I beat a little path to Solvay, and we said, would you help? And they said, oh, yeah. And I said, look, this is going to be a research project, and we're going to see how important nutrition is and how important creon is. If you could give us some supplies of creon. And so what we did, we set up a project. I can't go into a lot of the detail, but in essence what we did was we left the physiotherapy as the Russians already did it. We left the antibiotic program as they already did it. But we gave them creon, and we gave them dietary advice to go with the enzyme. And we set up this may have been more important than we realized at the time, we set up a regular monitoring so that every patient who was on the creon and on the diet was seen every 2 months and carefully weighed and measured, because up to then they had what you'd call a firefighting system. They would